All right, here we go. Chapter 35, Hydration and Homeostasis. Now, this is going to be in Module 12 with bladder and bowel hydration and homeostasis. So, just a reminder, I don't own this material. Under fair use, I'm providing lecture content for only my nursing students using this material. All content is for only educational purposes for nursing students and does not provide medical advice. Body fluid. So water is the primary body fluid. Water content varies with age, sex, adipose tissue. Water contains solutes. Solutes are like salts, so some of them are electrolytes and some of them are non-electrolytes. So solutes are particles that are in the water, and water tends to be the conduit to get things in and out of cells. So that's kind of how you think about that. Body fluid can either be an overload or underload. So dehydration, underload, overload, CHF, congestive heart failure, fluid overload, edema, swelling, right? Eventually that swelling gets to the lungs and overwhelms the lungs. So there are two fluid compartments. One is called intercellular, intra, within the cell, and the other is extracellular, or outside the cell, which could be interstitial fluid, so interstitial tissues outside of the cellular level. Intravascular, intra, inside the vasculature, so inside the veins. Or transcellular, between the veins, trans, like transdermal, so transcellular. So how do fluid and electrolytes move? They can move in 4 different ways. So osmosis, just consider that kind of like going across cells. So if you were to put your fingers in a bunch of water for 35 minutes, you would pull your fingers out and they would be all dried up, waterlogged, crinkly. That's when water got in your skin. Diffusion is across cells. Filtration, so filtration, think like kidneys. So movement of fluid and electrolytes. Active transport, and that takes energy. So osmosis, diffusion, filtration doesn't take any energy. Active transport takes energy. So how do we get fluid in our body? Primarily from drinking fluids. So the more water you drink, the more you get rid of. So the National Academies of Science, Engineering, and Medicine in 2019 made a recommendation. This would behoove you to know this. On most tests, this is an appropriate question for 2 to 3 liters a day. So question, women need 2,700 mils. So if you did the math, 2,700 divided by 30 mils per ounce, that's going to be 90 ounces of water a day. That's a lot of water. That's more than 6 to 8 ounce glasses a day, right? And men are 3,700, so if you do the math. You get 20% from your food or the metabolism of food. So consider if you're eating watermelon, you might get a little more water from it. And fluid intake is highly regulated by thirst. So there's a change in plasma osmolality, and the hypothalamus tells you that you're thirsty. The problem is that some people take that as hungry and start eating instead of drinking. So, how much urine can you make a day? So on average, you're going to make 1,500 mils per day. If you think about that, the minimum amount of urine that you make per hour is 30 cc's. So anytime that the doctor has an order for less than 30 cc's an hour, call the physician. That's not a recommendation, that's a guideline. So if you think 30 times 24, minimum output around 780, but your body is able to produce close to 1,500 a day and maybe making much more than that. The more you drink, the more you make. You're also losing a lot of fluid through perspiration, exhalation. Some of those kind of fluid loss are called insensible fluid loss because you can't measure it. And then through feces, you're losing 100 to 200 mils a day. Depending, right? If it's liquid diarrhea, you're losing a lot more fluid. If you're constipated, you're losing a lot less. So thought process. The hormonal regulation that's going on inside the body includes ADH. So you need to know your ADH, and you also need to know your SIDAH. So, syndrome of inappropriate antidiuretic hormone means that you're blowing up like a bullfrog because it's anti-diuretic. It's holding on to all the fluid. This is antidiuretic hormone. Antidiuretic hormone says hold on to the water, and that happens in the kidneys. In the kidneys, you're holding on to water to maintain your blood pressure. So a lot of medication works on that renin-angiotensin system. Angiotensin right there sounds like blood pressure. So reabsorbing water out of the kidneys, out of the urine, to provide for blood pressure. Aldosterone. So again, if it sounds like prednisone, it may be very similar. Aldosterone is another hormonal regulation. The thyroid hormone is regulating fluid. So if you're hypothyroid, you dry up. If you're hyperthyroid, you have a lot of extra water. And then the brain nitropeptide, the BNP tells you when somebody is in renal failure, in heart failure. It's a big lab that will be super high off the chart when you are in congestive heart failure. Heart failure, BNP, brain, peptide, just know that that's natriuretic uresis. So that means that it's holding on to fluid. So that number will go up sky high. 1,200 is easily an idea that someone's going into fluid overload. Someone's in heart failure. The heart's not pumping all the water to get it out of the body. It's going to back up into your lungs. Congestive heart failure. So, the major electrolytes in your body, sodium. Now, just consider that sodium and chloride are married and they never want to let each other go. So wherever sodium goes, chloride follows it. Sodium is an extracellular fluid and it regulates fluid volume. The kidneys reabsorb that sodium, so that's the big place where it's going to be occurring. Sodium is not necessarily going to be absorbed other places. It's more so in the kidneys. It's pulling back sodium or releasing sodium through the kidneys. Potassium is an intracellular fluid, and it can cause muscle contraction and cardiac conduction issues. So whenever you talk about potassium, just consider the heart, because those contractions are either happening too much or too little, and we have cardiac arrhythmias due to the dumping of potassium. If your potassium gets too high, same problems with cardiac conduction, muscle contraction. So a lot of people will say, oh, my potassium's going crazy. How do you know? Because I have restless legs. That may or may not be true, but it's a key thing that muscle contractions do occur with potassium. The interesting thing with potassium is that insulin goes in the opposite direction. So if somebody was overloaded on potassium, you would give them K-exolate, which would absorb that extra potassium and get it out of the body through the stool. Or you would take them to the ICU and they would need an insulin drip, similar to a DKA, a diabetic ketoacidosis patient. And your kidneys also eliminate that. And that we kind of covered on the day that we were playing with meds upstairs, because Lasix is a known diuretic that is a potassium waster. Spiractolone would be a potassium sparing diuretic. So whether it wastes or spares is a big issue, and you need to know which is which. Calcium is for bone health, and calcium tends to work in the neuromuscular function and the cardiac function as well. Insufficiency leads to osteoporosis. So too much calcium, too little calcium, you can have neuromuscular issues. So when you chick the cheek, called chick-fix sign, if there's tetaning of muscles, tightening of muscles, that's how you know that it's too high. Magnesium goes in the opposite direction than calcium. So calcium and magnesium tend to change places. So if you overload a patient on magnesium sulfate, you use calcium gluconate to reverse the effects of it. So these two go hand in hand together, but they're not going in the same place like sodium and chloride was. They're going in opposite directions, like your insulin and your potassium. Magnesium, you tend to hear about that one with alcoholism. Alcoholism tends to lead to low levels of mag. And chloride is bound to other ions, including potassium chloride, sodium chloride, right? It's a strong negative ion, so it's going to attach to a positive. So magnesium chloride, almost anything can be a chloride because of the negative ion in there, and that's in the extracellular. Phosphate or phosphorus tend to be bound with calcium in teeth and bones, and it has an inverse relationship. So if you get too much calcium out of the bones, it's going to follow it. And that's in the intercellular. And then bicarb is in both intercellular and extracellular, and that is related to acid-base balance that we'll be talking to. And that's regulated highly by the kidneys and produced by the body to act as a buffer when there's too much acid in the system. So if you think about bicarbonate, just consider sodium bicarb. Sodium bicarb would be like baking soda. So it's very salty, and it acts as a buffer. So a lot of old people will tell you, oh, just go get me some of that in a water, and I'll take it for an acid. That's the problem. They can throw off their body regulation by drinking too much of that. It does act as a buffer, but it can also throw your pH out of balance. So, safe and effective nursing care. A patient who is obese was admitted with a diagnosis of congestive heart failure. The nursing history reveals the patient has diabetes, smokes 2 packs of cigarettes daily, and is non-compliant with diet, exercise, and medication. The student nurse assigned to the patient states, let's focus on making them compliant, which will solve all the problems. Otherwise, we can't help them. What is the most appropriate response? Let's explore reasons for the noncompliance. This statement shows a bias against the patient. Let's discuss how you derived your priority of care, or what do you know about congestive heart failure? My concern is the words making them compliant. It's never going to solve the question, right? So let's see what they say. Oh, they didn't tell you an answer. All right. For me, I would say this is a bias towards the patient. I would want to know what they know about congestive heart failure. There's a lot going on in this question. There's a lot of places you can take this, but in fact, it is not all about compliance. Right now, our biggest concern is the congestive heart failure. Okay. Acid-base balance. So we're getting into the ABG part, which is fun. So acid-base balance, when we talk about acid-base balance, you're looking at acid being a compound that contains hydrogen ions, so the H plus ions, and a base, which is a compound that accepts those hydrogen ions, a negative. So thinking about the amounts of solution is reflected on the pH. So a normal pH value is 7.35 to 7.45, and we measure this by an arterial blood gas, which typically a respiratory therapist would pull from the arterial, okay, so on the wrist. They pull that out, and it needs to be put on ice and taken straight to the lab. So 3.45 to 7.45 is not a lot of room. So in between 7.35 and 7.45, your regular pH balance. Less than 3.5, you're acid. More than 0.45, you're alkaline. So then you have two systems which come to help you. Your two systems is the respiratory system and the renal system. The respiratory system will come faster. The renal system will come later and clean up. Okay? So consider that we have buffer systems in our blood to help us with this. So if we're getting a little acidic, our breath might increase. If we're getting a little alkalotic, we might increase our respirations. If we're getting alkalotic, we might slow down our respirations. And then renal will eventually catch up for us. Renal system will allow more or less out of the system. So when you have a fluid volume deficit, you're in hypovolemia, low fluid volume. It's also considered dehydration, which key signs of that: dry skin, dry mucous membranes. They'll be licking their lips a lot because their skin is so dry. Non-elastic skin turgor. So when you pull up their turgor and let it go, it takes more than 2 or 3 seconds to return. And you would have decreased urine output and decreased blood pressure, so your hypotension, which would increase your heart rate and a rise in temperature. So hot and dry, dehydration. You're also going to have fluid loss that leads to weight loss. Weight loss through fluids, plus or minus 1 or 2 pounds, probably need to call the doctor a day. So fluid excess is hypervolemia, and signs of fluid overload would increase elevated blood pressure, a bounding pulse, pale, cool skin, edema, ascites, so lots of swelling, crackles, and eventually when you get that JVD, your jugular vein distension, bulging veins, bulging fontanelle on a baby, that means way too much fluid. All right, so on assessment of a patient in acute renal failure, the nurse finds the following: distended neck veins, cool pale skin, and crackles in the lungs. The nurse should suspect the patient is experiencing, that is the key telltale signs of hypervolemia: bounding pulse, elevated blood pressure, increased respirations, and wet. All right, so the electrolyte imbalances are either hyper or hypo, and then the word emia in the blood. So hyponatremia, hypernatremia, hypokalemia, hyperkalemia, hypocalcemia, hypercalcemia. So make sure that you make it very clear if you're talking kalemia or kalemia. Kalemia, calcium, kalemia, K, potassium. Hypomagnesia, hypermagnesia, phosphorus as well. So those are all the words that you need to remember and know what is that, too high, too low. And then your acid base. So your acid base, in acidosis, the pH will be below 7.35, and that's caused by a retention of the CO2. So a respiratory issue, there will be an increase in CO2. If it's a metabolic issue, there will be a loss of bicarb. Okay, we'll talk more about this because it's very confusing. A loss of bicarb means the number will be low. The increase in CO2 means the number will be high. Okay. Alkalosis is a pH above 7.45, and they are blowing off the CO2. So their increased respirations tend to be anxious patients that are hyperventilating, so we give them a bag. The metabolic cause would be an increase in bicarbonate. So if somebody were to take a whole bunch of Tums, that would be metabolic alkalosis. All right, so whenever you get a pH, a CO2, and a CO3, what you're looking for, 1, pH. Tell me, is it acidic or alkalitic or normal? 2, then check the carbon dioxide because that's going to come into play first. That also tells you if it's a respiratory problem. If the CO2 is not high, then it may not be a respiratory problem. If the HCO3 is high, it may be a metabolic issue. Then 4, you talk to yourself about compensation, which would mean 1 or 2 of those numbers would be back in normal range, so it's coming back in alignment. Okay. And if so, is it partially or fully compensated? If 2 things are back in normal, then it's fully compensated. Sometimes it's such a fresh hit that it's not had time to compensate yet. Okay. We will go over these in class as well. Don't worry. So some of the nursing assessment pieces, you want to do a brief head-to-toe physical assessment. You want to do vital signs, temperature, pulse, respirations, and blood pressure, a daily weight, fluid intake and output, and lab studies. What are you going to do? A lab study? CMP, VMP, basic metabolic panel, or a complete metabolic panel? Complete will get you more information, but it costs more. Lots of things. Your analysis, all that stuff. So some of the analysis, the nursing diagnoses that you would do with your analysis of the data, either it's deficient fluid volume or excess fluid volume, at risk for deficient fluid volume or risk for imbalanced fluid volume. And then your acid base and your electrolytes might be an impaired gas exchange or a risk for electrolyte imbalance. So what do we do about these things? A lot of dietary teaching. So all those electrolytes, you need to know foods that they're good in, especially for test. Your test will have a lot of those. Oral electrolyte supplements, limiting or facilitating oral fluid intake based on whether you're over or under, and then potentially parenteral replacement of fluids and electrolytes, so IV therapy. You administer the prescribed IV fluid boluses and hydration based on the patient's condition, and you will choose an isotonic, a hypotonic, or a hypertonic solution based on that. So the doctor will tell you one kind of fluid or the other, and you need to know what these terms are and what fluids are involved in each one of them so that you're better informed and not just doing what the doctor told me to. So if you consider isotonic the same as a unit of blood, it's not going to cause a shift in fluid in or out of the cells, and it's just filling the gas tank. So when you're a quart low, you're putting in gas in your tank just to fill it up. That's exactly what isotonic fluid is. So it's 0.9 NS, which is the same as your body and the same as a blood product. So it doesn't cause big swings in or out of the cells. It's just filling space. So if somebody came in the ER in a trauma, losing blood, the best thing you can do is give 2 large bore IVs and start pumping in the fluid. Eventually, when we get a unit of blood, you'll pull in that blood as well. Isotonic is the same as blood. It's not going to cause big shifts. Hypotonic, if you think about it, hypotonic would be less than 0.9, so a half normal saline would be less than my body, so it may pull water out of the cell or it may shift water into the cell. What is it going to do? It's probably going to shift water into the cell. Okay, so hypotonic is less than blood or body fluids. Hypertonic, just consider that like major salty fluid. So there are some medications that we give, especially in traumas, intracranial pressure. If you had a lot of fluid on your brain, we would give you a special IV fluid that's super salty. So if we give you something that's super salty, it's going to pull the water out of your cells and make them shrink versus make them swell. Okay? So think about jumping in the ocean, which is full of salt water. You're going to be thirsty in a couple hours. Okay? So the approach to vascular access could be peripheral, central, or interosseous. Peripheral is your arm, your leg, whatever, right? It's peripheral. It's in an arm, a vein in the lower arm, lower leg, whatever. Central means central, right into the jugular, right into the arm, threaded up to the heart. Interosseous means just what it says it is, in the bone. So worst case scenario, we can get the drill and drill an IV into your sternum, into your leg. Especially children, we use a lot of chicken bones to practice this with the flight team because they need to be able to drill into a child's leg or into a person's sternum to get that fluid in quickly. It's a last choice, a last-ditch effort. And then we always have sub-Q infusions that we could do if we needed to, but again, the sub-Q route is not going to be as effective. Subcutaneous is used to administer meds, continuous fluid or nutrition. It's a home-based palliative care patient kind of a thing, and it can be in the arms, the thighs, the back, the abdomen. Think about this as insulin pump. The advantages of this is that it's low cost, it's ease of application. You don't have to have a lot of training to put the needle in, and then it's minimally infection risk and complications. The replacement of blood or blood products. For every time that you do that, you need to get a set of vitals, ensure a patent IV, and remain with the patient for the first 15 minutes after starting the infusion. I have no idea why that says 5. It needs to be 15 minutes. And what you're doing in that first 15 minutes is you're looking for a transfusion reaction, either allergic, bacterial, febrile, fever, hemolytic, or circulatory overload. If you hear anything out of the patient, stop the blood transfusion, assess the patient, grab a urine, and notify the provider ASAP. Do not throw away the blood. The blood needs to go back to the lab to be checked to make sure that it was the right blood type, didn't have any bacteria in it, and double check for circulatory overload. The doctor's going to give you an order for like Tylenol, Benadryl, labs, and potentially transfer that to the ICU. So here we go. Joan, age 18, donates her blood for a scheduled surgery. She's Jehovah's Witness and believes blood transfusions are not acceptable. She requires a transfusion after surgery. As the blood is transfusing, she states, "I know that this is wrong, but I do not want to die. Why do I need this blood?" She starts to cry. How should you respond, if at all? Well, it is her blood, so I believe that if it's your own blood, that is an acceptable thing in Jehovah's Witness. So what resources, if any, should you obtain for the client? Have someone come talk to her from the Jehovah's Witness religion. I know that this is her blood, so it should be more acceptable than someone else's. And what should be your initial actions? So knowing why she got the blood is big, right? So it's an education issue. I would want to make sure that she knows why she needed it and that it is her blood. But again, at the end of the day, get her religious group to come and talk to her. They are going to know more than we do about that. So, a nurse administering a blood transfusion to a patient in shock. After 30 minutes, the patient spikes a fever and reports chest pain. Their blood pressure suddenly falls and they become tachycardic. What type of reaction is this? Allergic, febrile, hemolytic, or circulatory overload? What do you think? What do you think? What kind of transfusion reaction would that be? So the most common is hemolytic, which tends to be the destruction of the red blood cells, and it occurs when infusing incompatible blood, which is a high antibody response. The complication is rare but fatal, so you need to take care of that. Hemolytic is the most common. Febrile would be just fever. Allergic would be more itchy. So if somebody it's itchy, we usually give them the Benadryl to keep them from having that. But the key is that after 30 minutes it happened. What happens is at the time that you transfuse a unit of blood, 2 RNs need to be in the room, double checking that this is the right type of blood and the right patient. That's where things can go bad. Okay? Circulatory overload reaction would sound a lot like CHF, junky lungs. They're taking on a lot of extra fluid. Extremely scary. But hemolytic is the most common type. I would be prepared and ready for that to be on the test. All right. Talk to you.